All right. So thank you so much, everyone, for joining the session. I think we can start now. This is Dr. Sharir. I hope everyone is well. All right. So it's good to have all of you with us. We're going to start now, definitely the session. Please mention in the comment section in the beginning from which city or country you are attending this particular session, right? So let's get started. Highly anticipated lecture. I think some of you were requesting about this one. Even though I'm sure everyone is expert on that one. But anyway, so exam related, what things are important, what things are not important. Sometimes there's so many confusion actually out there. So that often happens sometime actually. Yeah. So great. So here we go. We can start now with the session actually. Please confirm if it's the screen is loud and screen is clear and the voice is loud actually. Please mention in the comment section actually. Great. Good to have all of you with us. We're going to start now without any further delay, actually. So we have highlighted few points, few new things have been added, and I think we are good to go now, actually, with the lecture we have, actually. A lot of people are have going for the exam, so we thought it's the right time to bring that one and also share it in our video channel library as well at the same time. Without any further delay, let's get started with our very first own question. Yes, I hope you can see the screen definitely. You'll get to see often questions like, over the 50 and the below 50, it's very important to rule out. So, okay, postmenopausal, so surely more than 50, a female presents with enterosalient prolapse, and it happened to be an incontinence actually. Now, what is the management actually? Best possible management in a incontinence case. This is how one of the question we do have here actually. So, one of the incontinence related cases, what do you think? What is the right thing? Are you going for a surgery? What is the management actually? Let's say what is the initial appropriate? Let's say initial appropriate. What is something you wanted to do? Okay, so a lot of people are focusing on the pelvic floor muscle exercises. Yeah, which is good. Okay, let's add this line. I remember this question was given in that way, postmenopausal woman, and her age was, it was given like somewhere 77 years age. Okay, see, age-wise, even thing can change actually, right? So postmenopausal woman whose age is like 77 year or even 85 years presents with prolapse problem, and what is the best management in that case actually. So you see, just because of changing the ages and all this thing, the whole scenarios can change actually. So I put it in that way because a lot of people made a mistake on that one. Just they always think, okay, it's incontinence, it's always pelvic floor muscle exercises. It is not always like that actually. It depends on, as you can see, it depends on the age group actually, and I have seen that question coming more with the more elderly people group has been given actually, and separately a lot of question comes as incontinence we have discussed in the renal system in past actually regarding those things actually. Okay, so I put it as a pessary again, but it depends on the age group, it depends of cardiac status and a lot of other things. If the patient is fit enough, if the patient is you know the cardiac thing wise, if the patient is fit enough or not actually, right? So this is very very important. And please note, we do have approximately if you go at the end, there is almost like, yeah, 20 question for today. I mean, it's just in case anyone wants to know, actually. Great. All right. So let's go with the further. So this one, we put it as a pessary, actually. So postmortem ring pessary often, but it depends on because life expectancy, yeah, uh, less than 10, also like a fragile slash extremely old. We have also seen a question coming in that way. It was given, EF was given even with a 55 year, but EF was given 25%. So there was another question like that. Now, what do you think? What would be the answer? So EF, like in the heart, in the echo it was given like this, plus age 53, same question. Now, are you going for the incontinence even in that particular case? Okay. Now, what do you think? That particular question I have seen, the initial exercises are done and failed multiple time, and they're asking best. Now you will be thinking about surgery, but surgery not possible due to cardiac issues, right? So that question was like that. So first, that exercise thing, most of the cases we think about exercise initially like a, and it should be at least continue for like 3 months, that exercise, or even more. That's most important. So let's look into the question, what this question is asking actually. So more questions are coming up. Yeah, so just give me a second. Yes. All right. So next question is coming up now. Next question is coming up. Just I'm taking a second just to check something. All right. Just checking the sound is okay or not. All right. Next question, a 22 years old lady waiting like this and is an OCP and also is a smoker. So OCP taker, smoker. In counseling regarding her risk for breast cancer, what poses the greatest risk? Now that's an interesting question. Quick thing again, I'm asking, is smoking is something poses the greatest risk for a, yeah. Again, I'm asking, is smoking thing is poses the greatest risk for the breast cancer actually? Have you seen any sort of references and this, that in that case? So they did ask about the, yeah. So we have picked up here, I mean, because smoking is generalized, there's so many carcinogens and this, that are important. But at this point, her OCP, smoker, her weight, a lot of things are her. So her use of OCP, uh, there is risk. Her weight, that also has risk according to RSCGP. But I think according to RSCGP, uh, I think I remember that RSCGP thing wise, I think the weight thing was the uh, more risk actually. Yeah. So that's one of the thing. We also have to check, like, how many years the OCP has been taken. So she is waiting 125 and is on OCP, but they didn't mention how many years actually. That's another point actually. But as per RSCGP, as per Red Book, there's a book called Red Book, also known as that RSCGP. We found it that, um, the weight, this one is an interesting one actually. Often, because it's smoking is always comes in our mind as some very high risk. So as the alcohol, even teratogenicity cases, smoking is very, far ahead, even more dangerous than cocaine, the smoking, right? But interestingly, in breast cancer cases, I've seen a lot of references. Smoking is not the highest risk. It does carry risk, but not the highest risk for the breast cancer, considering the person's age group in generally in long term, as per the references, carries more higher risk actually. Okay, is everyone is uh, clear about this? Everyone is clear about this question? Yes. Yeah. So this one is one of the tricky question for the exam. I mean, you can bring a lot of hypothetical things about the smoking, but I think here the answer is tricky. It is as per RECGP actually. As I mentioned, like, normally we are supposed to maybe go for smoking because it is generalized. So here the answer, we usually think about that, the weight one, as per the RECGP. Yeah. No, no, same thing here. I mean, At the end, there is another similar question. I will also show you that one. So no worries on that one actually. But I think I remember I mentioned about that one in one of the gynae class, right? That the if the weight thing is mentioned, especially in this kind of risk factor about the breast cancer, you always choose that one if you remember that one. Now, 20-year-old woman came for a GP clinic for a contraception advice. She states that her mother and the sister had a DVT episode. Which of the following is the best step in care of the patient? Please focus on the answers. Okay, we can see a lot of things are coming. B, D, B, D. Best step in care of the patient, please to ask. Now, thing will come in your mind. Okay, let's go for B. Let's go for B. That's how it will come in your mind. But is it the B is the answer? But or I always mention you should also think about is do we have a better option? Always keep thinking, do we have a better option for answering this kind of question? No, I mean, so we do have a better option before going for this OCP. Rule out something which is even more bigger thing actually, like a thrombophilia. Now, if you go to the thrombophilia section of John Murtagh, if you go to thrombophilia section of the Medscape, you will find out that thrombophilia itself carries the 50 time higher or 30 to 50 something, 30 to 50 time higher risk of thromboembolic manifestation. That means the stroke, that even MI chances, peripheral vascular disease chances. So yeah, factor 5 laden. Thank you for mentioning that. Also, because of that factor 5 laden, so we need to rule out the thrombophilia first. And even though B is an answer, but do we have a better option? We do have a better option here in this question. So always look into the question. I mean, before answering your final take, just scroll. It's my tip to the exam candidates. Like before clicking and moving forward, just have a look. Are you missing any advice for the patient? Okay, this one is not difficult one. I remember I have taught this one. It's a reasonably easy one. If family history of like the DVT and also thrombophilic screening, but definitely it needed to rule out actually. Next one, a woman taking OCP for 30 gram of estrogen and now comes to youth hypertension. So OCP hypertension, very popular question. I'm telling again, OCP and the hypertension questions are very popular in the exam. And of course, so many women is taking oral contraceptive for a very long time can develop hypertension. Now, the question is what to do in these cases. Now, is it okay to continue the estrogen? No, because it will be even more dangerous. So of course we will have to shift it and shift it to something because her demand is probably yet the pills. So prescribing something alternative which does not contain, I repeat, does not contain estrogen. So POP is the better choice. POP, progesterone only pill, is the better choice in that case. Great, wonderful actually. So progesterone only pill is an appropriate alternative option actually. And OCP has a very interlink with the high blood pressure. So this is oral contraceptive is contraindicated when someone has a known hypertension actually. Okay, it's one of the relative risk actually. Yes. One thing I wanted to highlight here because you guys, a lot of people are having exam very shortly in few days. Please double check the relative and absolute contraindication of oral contraceptive pills actually. All right. So thank you so much, guys. Actually, all right. So this is like a thrombophilia screening. D was the answer of the previous one. Okay, moving to the next one. 5. A lady comes to the clinic with a this time. See, a little thing changed actually. Mentally retarded, same type of questions. Always do check if the person is having epilepsy because OCP related questions we have seen in that way, like epilepsy, like mentally retarded. Okay, these small things, might change the whole game. Okay, please clarify that one. So, lady, maybe 30 years, coming to the clinic, and she's mentally retarded and coming menorrhagia. Even a female mental retardation can have, basic problems. She says that she has been suffering from menorrhagia since menarche. So from the very beginning, she's having this actually. And she's probably 15 or 30. Now has non-compliance with oral drugs. So the drugs she's taking, the treatments probably previously given are not up to the mark. Now, what is the best treatment for her in this case? This type of question, I think, if you remember, straightforward answer, we expect you to answer this kind of question. We need to give something implantable. So that is the Mirena. Actually, everyone answered that one. I think 95% of you answered this one correctly. So mentally retarded, uh, this type of cases, like this particular thing is preferred. This particular thing is preferred. Mirena is preferred. We are into the next question. 25-year female uh, presents to you advising choosing oral contraceptive pill after giving birth. So, um, after birth, a pill, something they're speaking, looks an easy question, but this question does test it a lot. She used oral contraceptive before her last pregnancy. Very basic and very common in general practice. Doctor, I was using the typical pills, but now, yeah. So, and she's of course also breastfeeding actually. She's a non-smoker, and so what is the best possible choice for her? Now the question is, um, yeah, she's a non-smoker, breastfeed her baby on demand. The question is she going to be pregnant soon or not? That's another important question based on a lot of things actually. So it's been 2 weeks already, see guys. It's not like just like the question is always check. Like I'm answering on behalf of a lot of people are answering no contraception needed. A lot of people are answering that one too as well. Uh, like no contraception and things are needed. Some people are answering like that. So as far as I think, dear doctors, as far as I think, dear doctors, in this particular cases, no contraception can be risky. She can be pregnant again. No contraception can be little risky, and she can be pregnant in that case actually. So I mean, and sometimes patient does not reach out to the doctors. Always not every patients are same. So accidentally she might get pregnant in it. So it's better, breastfeeding period, the classic one. The breastfeeding period would be that classic one. Sorry about that. So we start position only pill, position only. So that's better actually. Okay. So B is the likely answer. So let me just make this one. So patient is not considering conceiving again. You'll get to see this kind of questions actually. So the most important thing in this type of questions, like let me have you guys. So small tips. Patient planning to conceive soon, then you know probably the natural way you can patient not considering patient not considering conceiving soon, then definitely pop. Yeah, also please note breast feeding cases also you consider pop as a uh, better contraceptive. Yes, it's a breastfeeding period, my dear. It's a very basic. I'm sure you learned this thing in MBBS as well. During the breastfeeding period, it's POP. Okay. Okay. Next one, we're going into another one. Uh, yes. A 26-year-old comes with a repeat prescription. Obviously, she had headache with visual disturbances. So, what is the best advice? Now, this time, this one can be your key line. What is that? The visual disturbance. And she came for a prescription. It's not as she's already taking it. So always check in the question carefully. Some people think or pretend that okay, maybe this is already taking OCP. She is comes for repeat prescription for OCP. So means she probably has used it and now again came for a OCP or the right OCP advices. Actually, everyone in those country has a GP. So what is the best advice in this particular case? Now, quick question: is visual disturbance uh, can be a red flag? I repeat, is visual disturbances can be a red flag in some cases actually. Yeah, it can we mention it can be an aura? Can we mention it can be associated with migraine and this that? Yeah, so we can probably say because a headache, so migraine with the aura, it's a possibility. So migraine with the aura, it's a little possibility in this particular case. Okay, so please keep it in mind that this particular question can be, yeah. So this particular question can be, yeah, discontinuous OCP recommended alternative actually. This is the issue. Okay, now if we enter into uh, certain migraine things, let me just take some time here. So migraine patient and asking for pill. Now it's migraine patient with aura. You have to consider this thing, breakdown. Okay, breakdown of this type of question. Now what is the right one? Migraine patient with aura. Migraine patient or aura asking pill. It's also an important thing whether the patient is asking for a pill or not. Okay. Now, first thing first, can we recommend uh, oral contraceptive? That's not a best idea. If they're asking for a pill directly, then it's a pop. Now, let me recreate the same question, asking for advice. Now, is it POP or now is it same? No, now in this case, it's barrier. Now clear? Wonderful. Again, let me create another one. Migraine patient. This time, let me create without aura. Without aura, asking for pill. What do you think? Yes, we can yet give a little bit load. This is reference as per the John Montague. This is reference. This thing is already present in John Montague. So low dose estrogen actually. Okay. Second, migraine patient without aura, asking for advice. Final answer. Final answer, please. Barrier again. So everyone clear like how to tackle this kind of question next time? Everyone is clear? This is a classic one, always tested in the exam. But I'm sure, in any way, if it is given, the migraine with headache, migraine with migraine with aura, migraine without aura, you will be able to answer this kind of question. Yes. A 16-year comes with periodic pain, cycle is 5 to 6. What is the best treatment in that case? 16-year. So what is the best treatment? Now, in a 16-year, can you say this is a case of period pain? So can you say this is a case of dysmenorrhea? Yeah. And for the periodic pain, definitely uh, primary dysmenorrhea. Well done, my dear. And mefenamic acid and the lifestyle, as per the John Murtagh. We should also consider this kind of question. Sometimes treatment can be oral contraceptive pill if the patient is also looking forward to pills actually, because OCP will do the dual benefit in which way? One, preventing pregnancy. Secondly, also gives support in this case. So some cases OCP is not only used in preventing pregnancy, but as a hormonal treatment it's also been used actually. Okay, but in this particular case it's a mefenamic acid. I'm sure you all can relate with this question. Yes, mefenamic one in primary dysmenorrhea cases, it can be given, or even menorrhagia cases, because mefenamic is nothing but also NSAIDs. Okay, so it can be technically used in both cases actually. Yes. All right. I mean, initial phase, of course, actually, but if the bleeding is moderate or severe, then you have to switch it to tanexamic or something else. Okay, that similar question. Delivered a baby breastfeeding. Now, this one wants to conceive as soon as possible. Now, what contraception you will give? Now, we have seen this question just a while ago, right? Very little while ago, we have seen this one actually. Okay, let me just improvise this line. I have a little bit improvised it actually, after thinking some time. Initially, how it looks like, it's a no doubt, it's a barrier. It looks like actually, uh, but MC is not as simple as possible. So I little bit improvised that. Recall one we got. We improvised a little bit actually. We felt I checked few of other years question. So I realized like one that missing puzzle is there. The lady just delivered it. She's breastfeeding constant as soon as possible. Wants to like again constant as soon as possible, but would like to like have some temporary contraception in the meanwhile. Okay. Yeah. So what contraception advice you'd like to give actually? That is how that question, because the initial one we received uh, looks incomplete actually. Okay. Because patient will tell you a lot of information about whether you like to use contraception or not. These informations are usually mentioned, yes. So between B and D, if she's mentioning like using short, I mean, she wants to conceive as soon as possible, but it doesn't mean that naturally when it happens, it happens. She will decide definitely, but for a short period, maybe after 6 months, like the for the mother, after 6 months, then the another kid, they want to plan actually, after having another. So that is how it does actually. So in this short period, because the initial time frame is only like up to 1.5 month or 2 month, that's the natural support actually. But after that, you still need the POP. It depends on when the patient wants actually. Okay, but if she mentioned that using a short contraception, then it's the POP is the choice, because it's the pill for the breastfeeding. Yeah. Someone, yeah, good one, my dear. Yes, chameleon. This MC examiners, many time I posted. you know, they're like poets. What they want to express, probably no one understood. A better word for them rather than the chameleon, I think. All right. All right, everyone. Coming to another one. Okay, little bit different and probably a less recent tested one. 30-year woman referred to specialist, especially gynecologist or obstetrician, requesting permanent contraception. Okay, twist and turn and changes. Husband does not wants to go for sterilization, you know, whatever reason, but he supports her decision actually. Like, yes, a permanent solution we need. And let's see. She has 2 children and is concerned that she does not want more pregnancies. I mean, probably their family is complete, or they're sure at that point they just not want more pregnancy. So, what is the most appropriate next step in the management? Already mentioned the husband is not going for, yeah, but he's supporting the decision. So, in that case, what to do? So, I think best possible is I think the tubal ligation. I think, yes, best possible tubal ligation actually. But I think, in this particular cases, if there is a option given that um, call both of them together and talk face to face. Do you think that can be another answer? I repeat my words. If in this particular cases, organizing a session and talk to them face to face, because see, you know, uh, doing this particular surgery in female and doing this surgery in male, the male one is much more easier. Honestly, actually, it's not a intra-abdominal or anything. It's just, yeah, quite a easy procedure. So in that, if that particular option is given, probably you can also choose that one, that face to face, and tell pros and cons about the male, sterilization procedure actually. Yes. So, but it's not given. So just be aware that option can be given in another one. That option can be given in another one actually. Yeah, the patient can take decision on whatever, because yes, husband's consent always not legally required actually in that way. But yet, uh, if that is the thing, like a convincing something, yes, yeah. Next one. You heard about this particular thing, Yasmin, and is all contraceptive preferred in Australia because actually. Now, what do you think? That's yet in the market. Yeah, someone was asking in one time class, doctor, is that in market? Yet is that in market? Now, yes, so very good. Now, some many people will be very happy. Now, the question about, does it actually decrease the weight even when they have done researches? So, thing is, the only thing that was evident, that particular pill is uh, related to less weight gain, but it doesn't mean weight loss. You understand my point? And they totally brand it, and they do some marketing with it in different ways, reducing the weight. Actually, originally the evidences shows it does not gain weight in such way as like the others actually. They totally, what a marketing idea actually. So, see, as per even in March 2025, there was something, yeah, pharmaceutical benefit scheme actually, and that company might get some penalties and this that actually. So it's still, things are under reviewed and this that, but so it was a bit marketing strategy. Yes, that's okay. Great. All right. Yeah, but another thing, I mean, prevents that heavy and that bloated feeling. That's a quite a popular one actually, rather than the weight one. But they strategize the weight one more. That's how the everyone got attracted actually. But uh, after using it, there was a lot of positive thing, as like the other pill. There was a lot of side effects in this, that like heavy bloated feeling. That one is quite a less actually, evidence wise. Okay, next one. A couple comes to the clinic with a permanent contraception, having their families and reliable option, which are most appropriate procedure. Interesting. So seeking for permanent one, and this time, yeah. So little changes things, and vasectomy of the husband thing is given. They're seeking that advice. So as a doctor, you are giving the right suggestion. So of course, the vasectomy of the husband, you say it's easy, it's convenient, and this that. So yeah, vasectomy and the tubal both are there, but vasectomy is much simpler, safer, less side effects. This that. Whereas tubal can be, there can be surgical risk as well. Okay, the 28 actually. So 28 years old female comes to the physician for contraceptive advice. She has history of migraine with depressive disorder. Her BMI is 33, so more than 25 is bit overweight. So contraceptive method you will advise her. So the migraine thing is involved here. First, we have to see again if she's demanding any pill or not. Quick question: is she demanding any pill or something like that? Not really. So since uh, let us see this one. Physician with a history of migraine. Okay, we do have the migraine thing. Right. I think I forgot to add a point. Yeah, just let me then straight with aura. Sorry about that. I missed that one. All right. So migraine with aura related questions. Yeah. Again, if you want to go for the pop and this that, in that case, all right, it's okay. We got it. It's okay. We have already discussed it, my dear. Explanation is already given. Actually, explanation is already given. Please have a look. Say migraine with aura, and she'll be interested in pills in this kind of question. So yeah, all right. So no worries. We know the explanation. Why not? Why not? I mean, rather than we focus like what's the question. Okay, next one. Let's not waste time into that one. Patient comes to asking for OCP. She reports that she has been experiencing migraine. What to do? Oh, again, a tough one. So migraine with OCP related question can give us a lot of trouble. Looks like E can be because migraine with aura, without aura uh, can be very important. Tell her that OCP is contraindicated in her condition. Both looks quite okay, but this one is okay. This one is okay. When two are okay, which one is more like an advice and this that? So we need to first assess. First, we need to uh, experiencing migraine means we need to take more general history to rule out if she's having some, say, visual problem or some sort of weakness or things like that. So we need to assess that one first actually. See, so same type of question, a little bit extra tail and extra advice might change the whole game actually. Okay, so these are the things we just have to be a little bit careful actually in the main exam. Just check, like asking for a pill, asking for a method, or there is any better advice than other things. Okay, female using 30 milligram OCP prevent continuing painful. She wants to conceive after, okay, like after 1 year. What will you advise in this case? So, not really asking exactly for a pill. She's already using OCP. So, quick question: do we recommend pill for like another 1 year? That's an interesting question as well. Do we recommend a pill for another 1 year? In our country, it does. But is she asking for a pill? She's looking for an advice. Also, please note the patient has some painful period. Some people are ignoring this part as well. So there's dysmenorrheic problem were there, and yes, I think other than A, D is a better option. Even E is also an option actually. So NSAIDs as a way of mefenamic acid, you know, you see patients taking OCP, but patient's chief complaint is painful period, so dysmenorrhea at this point actually. About OCP already it's been used because OCP can be helpful in dysmenorrhea. And they have used 30 milligram of OCP, as someone mentioned is correct. Um, yeah. But again, at the same time, long OCP using also carries risk of cancer, isn't it? I mean, we understand that one, but already she's been using the OCP for some time, and now it's like a one more year left. Best possible answer is missing. What do you think? All option are pills except for the D. D1 as a pill, like of course NSAIDs for a short time and using the barrier. So my thinking is going more towards D. Apart from D, E is a good option actually. No, no, I don't think so. NSAIDs for that particular time being. NSAIDs is always given for a short time, my dear. I mean that mefenamic acid treatment is always given for short period of time. Yeah, or during the time they are feeling that pain actually. It's of course not, that's so it's a good difficult one. No, I think they does encourage barrier. I mean, if patients are comfortable, patients' comfort is matter. Some cases, some patients might tell I'm not very comfortable. Yeah. So then thing can be, you know, changed actually. Yeah. So as long as the patient is telling, okay, I'm not going to do this or that, uh, then it can be different actually. Yeah. But like at least for this time, the patient has been used OCP for some time period and also having this pain. So I think uh, using the barrier and using that mefenamic acid for short term, because you can also change it later actually. That's the thing. All right. All right. So I think I pick up D, but I will also keep eye on the E, as mentioned by some of the doctors. I mean, increasing the dose of the OCP. Why I didn't went into there? Because patient didn't ask or demand for a pill. That's one of the reason. But we also know that OCP can be also used in dysmenorrhea cases at the same time. Probably for that reason, that pill has been used actually, and it is not possibly working more. So for her, rather than you know this conceiving period or using barrier or OCP, her pain during the period has become the primary problem now. Now, in that case, if OCP things are not working, in that case, I think the NSAIDs or the mefenamic, of course, that works better, is the better choice. You have to also focus on that primary problem. Her primary problem is painful period dysmenorrhea. Only female knows how much it hurts, actually. There is a line like that. So, uh, in Australian context, if someone is in pain, they're very much focused about controlling the pain. So based on that one, I think D is also very important actually, because if we are giving D, then I think the pain thing, it is also working better. You know, yeah. So for now, I think it's D. All right. Yeah, and NSA is the best treatment for dysmenorrhea at the same time. Okay, next one is a extra thing question. Extra means, woman with 3 kids and she has a different problem, ENT problem, autosclerosis. It's a conductive deafness problem, right? Which contraceptive method is considered best for her? Now, given an additional problem, so again, I'm telling guys, please read about absolute and relative contraindications of oral contraceptive pills. You need to rule out if that's one of the, yeah. So in that particular case, I think, what do you think? Uh, what is contraceptive method best for her? What do you think? Is it D or the E? So D and E both are quite a close. Hmm. I think her problem is more with the oral pill. I think. See, oral pill has certain level of side effects that the IUCD does not. Okay. And a quick thing is the working way of IUCD and oral contraceptive pill is similar. Just wanted to ask our dear doctors, is the IUCD way of working uh, and the oral contraceptive pill, are they working the similar way? It's not actually. It's not actually. So I mean, don't get into that way that oh, yeah. So both of them are technically correct actually. Yeah. So I think this time we choose IUCD because it's different. It's not that typical hormonal ones as like the pill. Okay. So we picked up the IUCD actually. Yeah. All right. A lady with obesity, hirsutism, PCOS. So again, you are expecting PCOS related and this hormonal related question. Don't get frustrated. Now, asking for a contraception actually. Asking for a contraception pill, I think. Perhaps we understood. So in that case, oral contraception. So asking for contraceptive pill. Contraceptive pill, I believe. So we'll go for a A in this particular case. Yeah. So PCOS, I mean, main question will tell you in more specific way. They want to conceive or they does not want to conceive. They will tell you very clearly this kind of thing. So PCOS cases, female who does not wish to conceive. Some of the question can be a little fractionated because these are exam recalls. So later we give that explanation so that uh, based on our advices, you mark in the question. Advised oral contraceptive is the best preferred method of contraception in that case. Great. Um, I hope you remember about the PCOS. Certain things we request you to read from PCOS. PCOS can come as a infertile couple. In that case, male to be tested first as like the sperm count. And for both infertile couple, female and male, FSH and the LH are some of the initial tests you need to do. But please remember, as an infertile couple, and this that the question can come. In PCOS, there is a triad, uh, starting with the menstrual irregularity, then androgen excess. There will be, hair on the faces in female, which is usually unusual. But if there's a hair, beard, and this that, so may think as a PCOS, and there will be ultrasound showing cyst in the ovaries. Actually, yes, Rotterdam criteria. Yes, you can remember. So anyone having menstrual irregularity, any female is having menstrual irregularity, any infertile couple, this relevant questions you'll get to see a lot in the main exam actually. So more things we can test as like ultrasound we can do if there is any structural cause of menstrual irregularity. Then we would also like to do a TSH test. If it's still yet not working, you might think about a prolactin to rule out if something is not because of pituitary even. All right, great, great. We also get to see about a missed pill. Some people are taking pill like a day to day. 25-year woman presents to you missing one combined oral pill yesterday. She usually takes her pill every night, this, but forget to take it. So she missed a like pill actually. So she reports no sexual intercourse since the missed pill because this information is also important. What is the most appropriate advice in that case? Okay, so I think looks better. Yeah, take that missed pill now. I mean the previous test one now and today's pill, yes, at the normal time. The, the more problem started, yes. Yeah, it's a good question actually. In which part, she probably have missed actually. I think till yesterday she has missed actually. So maybe one you take in the morning and one the scheduled one in the evening. Yeah. Yeah. So take the pill now, today's and the normal time. It's a very basic one, I think. Very basic one. Yeah. So this is a like classic one related to missed pill actually. Okay, next one is a tricky one. 17 years comes to you and says that going to have start this and best contraception and safe. What is your advice? Would likely to give her in these cases? Yeah, interesting question. All of them look quite, right. So please choose one wisely. Yes, please. A lot of people are with B, a lot of people are with A. This question is mostly still about a young female going to start her life in a way. So advices regarding that is more appreciated actually. Since they mentioned HPV booster, so probably she has already vaccinated. So I think D we're not considering here. For Australian context, actually, between A and B, both are, but this question is mostly you see what advice because she comes to a GP and basically she's speaking about the activities because at this particular age group, people does not always follow rules and this that. So I think she's in high risk of something like STI. She's very high risk of STD or STI. So in these particular cases, actually, screening the chlamydia would be more better, actually. Yes. The priority would be more, yeah, ruling out chlamydia because chlamydia is often asymptomatic. So I feel prefer chlamydia because often asymptomatic. So screening for chlamydia would be more important, actually. So Australian STI management. Any sexually active women under 25 years should be screening from chlamydia every 12 monthly or every 6 months. Yeah, if they have a new or multiple. So every 6 months, if they have a new or multiple partners. So please, you can follow up this line. You can follow up this line, particularly this line is okay. Good. Happy with the answer, or maybe showing the answer. Yes. Yeah, you might always want to choose PAP, but you have to see is like very young and mainly going for contraceptive advice. So I think best possible, we go for A at this particular point. Good for us. It's a little extra. I mean, there was I think previously an old recall. I think I removed that one. I just kept that one. It was given as a phenytoin. So phenytoin is nothing but an enzyme inducer that can significantly reduce the effectiveness of oral contraceptive pill. Um, this kind of question also we have seen coming multiple times. Uh, I hope you remembered that one. Like, if we just talk about very shortly about that kind of question, say how enzyme uh, inducers work. Enzyme inducer. If you give an enzyme inducer plus the other drug decrease, you need to remember this one, decrease activity of the other drug actually. Say inducer like phenytoin or carba, whatever. Then the other drug is oral contraceptive pill. What will be the result? Decrease activity of OCP will lead to pregnancy, right? So inducer induces cytochrome P450, decrease activity of other drug. So you can remember the enzyme inducers names, more names. You can find many mnemonic in the Google actually, especially regarding the enzyme inducers and inhibitors. I usually use and try to remember the enzyme inhibitor names because inducers are so many to remember rather than there are limited number of enzyme inhibitors actually. All right. So that's the thing. You can, my dear, just Google it about enzyme inducer mnemonic, enzyme inhibitor mnemonic. You will find many. By the way, grape juice or wine is an enzyme inhibitor. Did you know that? Grape juice or wine is a enzyme inhibitor. Yeah, and we saw that one in some part 2 exam. Interesting. Okay, young girl has a uh, okay. Young girl has a history of epilepsy, well controlled with phenytoin. Now wants to have an OCP. What will be your yeah advice? She has epilepsy, so taking the pill like regular pills are difficult. So I think for this kind of method is better for her. Like, so summary here, if we make a short summary, like a previously seen mentally retarded, for them taking pill is difficult. Now we found this epilepsy. So any cases where pill taking is difficult, I repeat, any cases where you've seen pill taking is bit difficult, maybe you consider the IUCD. Another thing is oral contraceptive pill and IUCD works in the same way. Uh, what do you think? It's not actually. It's not actually. So don't keep that one in mind that okay, uh, it's just not an alternative or this that like that. They both work in very different way. Rather than using the IUCD can lead to ectopic pregnancy. You know, please keep that one also in mind actually. So PID or ectopic chances can be higher. Okay. Next question. 38-year nulliparous. I hope you understand the difference between nulli and the multiparous well. 38-year nulliparous comes to you like first timer into GP clinic for again contraception advice. She revealed that she has a problem with premenstrual headache. Her sister has a breast cancer. Which of the following is important contraindication for the prescription of an OCP in this patient? What do you think? What is the right answer? All looks quite not even close. I think many of you. Breast cancer, past recurrence, absolute contraindication. Again, say so. Relative contraindications and absolute contraindication. Please double check. Highly also breast cancer or I think I would say the oral contraceptive pill risk, breast cancer risk. These are also important. They mix up with OCP things in that way. Okay. Again, breast cancer is an absolute contraindication. 53-year woman comes to you, complain of hot flashes, very popular in the exam, postmenopausal, um, premenstrual, uh, many cases like that. So 53, of course, is a postmenopausal because over 50. So flashes 3 to 5 minutes, vaginal dryness, vaginal examination showing atrophic vaginitis. Very classic question, like postmenopausal developing atrophic vaginitis. Probably they also have dyspareunia if they're sexually active, probably. Okay, hysterectomy was done 10 years back. She also has a history of DVT. All right, big risk. What is the appropriate treatment? Interesting question. Now, it will be a close call. Should you go for a low dose, you know, oral? Or should you go for like vaginal estrogen? Let's see. Yeah, so we picked up here vaginal estrogen cream actually. Yeah, instead of low dose estrogen, even can be considered actually, but why didn't choose that one? Like a low dose, particularly B is a close one, by the way. Transdermal estrogen, like even though transdermal estrogen would not be appropriate because even transdermal systematic estrogen can carry some risk of DVT and should be avoided in DVT patients. Yeah. So about the vaginal estrogen cream, like very minimal systemic absorption because it's like the routes are different. So it's considering relatively more safer in DVT cases. So E is much safer than B. So E is much safer than the B. Oral estrogens is no way, you're just trying to kill the patient if you're just considering E. Because it's a directly oral estrogen and you are giving in DVT, you can't do that, right? Yes. So if we make an, I hope that's clear to the dear doctors. Okay, this one and next one. 10 weeks pregnant comes to you at a first antenatal visit. Okay, congrats to her. On examination, you can see the strings of IUCD like this. What is the next step? Yes, please keep going, guys. I'll tell you, two options are very close. One, perform ultrasound to confirm the placement. One, remove the IUCD now. So these two, we first thing is that can be even more dangerous, leaving the IUCD in the place. Okay. Let's double check the question. 10 weeks pregnant, obviously, on exam, she see strings of IUCD. Now, from where it came up? We picked up C, even though most of you have answered E. This can be the presence of any IUCD during pregnancy significantly. So it's like small piece, larger piece. Keeping an IUCD carries risk of miscarriage. Keeping an IUCD, uh, yeah, in any way, because a lot of people don't realize that they have that IUCD and they got pregnant and this that. Yeah, they forget to remove it actually. Yeah, yeah, miscarriage it can happen definitely. I think some people maybe in the gynae field can tell more. I think if there is a hypothetically different answer. As far as I know, I mean, uh, keeping that IUCD during the pregnancy uh, can be very risk and should be removed. It's not about doing an ultrasound and wait for some time. In between that, miscarriage can happen actually. Yeah, even in these 1 2 days which you are taking for um, doing that ultrasound and this that this can happen. So it's better to remove the IUCD as soon as possible actually, because in any way it's a risk during the pregnancy. I mean, someone asked if it's like by the third trimester it should have been already removed actually. We cannot keep those kind of thing. Yeah. I mean, the basic is like that. What do you understand? The last question is very tricky, I would say. Okay, Young comes to you. But anyways, if anyone has any different thought, let us know in the comment section. Thank you. Yeah, I totally agree on that one. If no string, then because we do have chance, then we can do an uh, general ultrasound to rule it out. Okay, Young lady comes to you 10th day. She missed her pill on the day 6. And now, previous question, 1 day missing pill. Now she has a missing pill day 6, 7, 8 days. She had intercourse. Now, last question, she didn't have the intercourse. Now this time she has intercourse. She took her first pill from a new pack today. What is your advice for her? So 2 days missed pill. I think it's a straightforward emergency contraception, isn't it? Yes. So if two then missed and has done intercourse, in there's definitely it's an emergency, contraceptive pill. Definitely. Yeah, I think emergency contraceptive pill is a right choice in this case. Yeah, maybe these charts can help sometimes. I'm not sure, you guys are having some sort of chart like this. So missing two pills, what you can do, missing one pill, what you can do, like you can just check. If you can take a screenshot. So missed one pill and missed two pill. Is another thing missed three pills. Okay. Next one. Which would be the best option for OCP for a smoker female? Okay, she's a smoker mainly. I think it's a pop. Yeah. Oh no, why Mirena here? I think it's pop. So for a text like, smoker age 40 or more, personally pill is more appropriate. Yes. One more thing. If there are option came up that, best suggestion as a quitting or something like this. Yes. Yeah. So best option for OCP. So please always check the question. All right. So we didn't take any break, but we don't have much left. So that's why we didn't take that break. A woman who had delivered baby 6 weeks ago and is not breastfeeding came for advice for contraception. Her profile was written, do not prescribe OCP. You find out that the husband does not want her wife to use OCP. Okay, fair enough. What would be your approach? Now, question is in Australian context, uh, is it like she has to abide by the husband's wishes? Yeah, anything like this. Uh, that's how it does not work there. Yeah, so tell her that she has right. If she wants, she can use the contraceptive actually. She has a right to use contraceptive. So there are cases like some people don't want to use because they want if there are more kids, it should have naturally this that. But yeah, in Australia, things are different. Maybe she does not want any more kids. Is very difficult. Okay, this looks interesting. One more question after this. 37-year. Uh, this case is about secondary amenorrhea. Maybe can be anything endometriosis or anything. 7 months of duration. BMI is 24. Looks okay. FSH, LH levels are given. Stradiol at lower limit. Prolactin level also normal. Urine pregnancy test excludes pregnancy. She's not pregnant. So not pregnancy. No pregnancy. Ultrasound reveals some cyst. She desires to be pregnant in future. So she wants to conceive. So what would be the most appropriate management in this condition? Interesting question. So secondary amenorrhea case. So 37 hormone replacement. Not really. Not really. I think that's the wrong answer. Yeah, we understand one thing. It can be a case of, is it possible this can be a case of primary ovarian insufficiency by any chance? Should we with this one for PCOS or primary ovarian insufficiency? We need to double check because in PCOS there is like 10 to 12 Cs, then LH is to FSH, there should be some differences, right? LH should be more higher than FSH. Anyway, LH has to be higher. Mm, FSH is a bit high here, so you might think about maybe some sort of early age menopause has happened. Good point. Yeah, FSH is 3 times higher, I think. Yeah. Oh, primary ovarian failure. Okay, ovarian failure. Those cases, FSH level. Let me show you. Wait. Okay. So early onset of menopause, say there's something like this before the age of 40, secondary to ovarian follicle, whatever. In that case, LH and FSH things would be generally raised. Estrogens will be decreased or in the lower limit. Yeah, like a premature ovarian failure. So as you say, if FSH increase and estradiol decrease, these are the two basic important things actually. So we have to, like, I remember from this slide, checking bone mineral density is very important, BMD, and if necessary, hormone replacement therapy can be a good option, I think, in these cases. So guys, I think if our menstrual cycle has stopped, then see, hormone replacement therapy is of two types. One, cyclical and continuous. They didn't mention, so either of them. I think this is okay. What do you think? Yeah, totally a twisting question, right? I mean, certainly looks like whole like a, yeah. So it's not PCOS as um, FSH is high here and low estrogen. This is premature ovarian failure, perhaps. Yes. Better? So the treatment is hormone replacement therapy, cyclical or continuous. Two types available. Yes. Okay. One more again, a last control thing before we left. So female smoker mother, yeah, she's 65, personal history of benign breast disease and OCP for contraception. What is among this may not be involved in breast cancer causation. Now, let's go. Again, it's tricky. Earlier we discussed like about smoking being a little, less. But I think, we have solved a uh, question. Earlier, I think we have solved a question regarding like this, right? In one of our classes, I think a similar something like this. So, final answer, I think we should go for a uh, benign, I think breast disease more, I think. I think in John Murtagh, I think you will find it about the risk factors of the about the breast cancers actually. Yeah. See, benign breast disease is not like we're thinking more about the malignancy always, Yes. So I think it's D. Again, a controversial one. A controversial one is very difficult to get exact reference. Yeah, but as far as our SCGP things from the breast cancer we have learned, I think the benign breast disease and also John Murtagh, there is a risk factor list of. So I recommend you guys to double check the risk factors. Also check the oral contraceptive pill relative and absolute contraindications. One more time, please check the premature ovarian insufficiency. Yeah. So yeah, very close in between these two actually. Yeah, I think in John Murtagh this line is given though, but again hard to choose again smoking. Yeah. The both I mean find quite close references actually. Yeah, I mean I know that benign breast disease thing is given. I think we have discussed in class as well. Breast cancer risk. Okay, let me check it. Yeah, very close. Yeah. Okay, let's check this one. So in AACP, just for learning purpose, we're checking. You know, as I said, very close. I mean, this is mostly related to those tough pilot question used to come because those are like research based, like whether smoking is more involved or smoking is less involved. Technically, it's involved, but how much involved? Like those are kind of like research project. We all know that smoking can be a risk factor for every type of cancer, but how much it involved in now coming to this one, nulliparity, early age menarche, age at menopause, cancer of the breast. Okay, any sort of cancers. Okay, pregnancy, this one. Then age, the hormone replacement therapy is of course very dangerous. Obesity, never breastfeed a child. Okay, interesting remark. High risk breast tissue, and also the genetic. Okay, I think we can also put. I think, and in RSCGP there was another one was mentioned is the obesity, if you all remember. So different type of chart, we saw different. I think. So tough call. So the last one, I think I leave it up to you guys. Uh, the very last one, actually. It's a tough call, actually. Yeah. So keep searching on that one. Yeah. Till if I find something better, I will definitely uh, inform you guys. So thank you so much for attending our session related to contraceptive. I hope it was helpful. Um, all the best for all of you. Thank you so much for joining this session. And yeah, it was a long-awaited topic. I think few new also came up. Added. I hope you will get a clear view. I will be posting that one in the video channel, so it will be available in the video channel. Thank you so much, guys. Thank you. God bless, and best wishes for exam candidates. And one more information. Um, I think we would also like to take a screening class. Uh, Let me just tell you that one because one of the screening that video was bit old, I think. So I think yeah, so this year's end or next year's beginning, the exam candidates that will be important. So 8th of November, we will take a same time, we'll take a screening class, 8th of November. Okay, for all of you in the video channel, we'll also go live. So please keep eye on the one more thing, guys. When you are in the video channel, we're sharing a Zoom link. Don't forget to tag your study buddies actually, because then it goes to their timeline actually. Okay, thank you, my dear. Yeah, I think in coming days, maybe Dharma, I will try. Thank you, my dear. Yeah, because John Murtak new version came up. So I think with the new version in the new batch, I'll be trying to update a new one. Thank you. Have a lovely day. And by the way, in the new batch, I think we'll start with John Murtak ninth. Actually, I'm updating the ninth edition. Actually, it has arrived from Australia. Thank you. Good luck. But those are going for exam, especially November and February. You don't have to think much about the ninth edition. But if you have exam on April, May, June, then you should start, um, think about ninth edition as well, revising and checking some of the differences. Yes. Next batch will be on December 15th. Thank you so much again, my dear. Yeah, of course. Any older student comes, we only take $50 actually instead of 450. Yes, in the yeah, no worries. Thank you.